Hi, this is Miss Walton, and today we're going to be discussing integumentary disorders. Some of those disorders are things like atopic dermatitis, acne, impetigo, cellulitis, scabies, burns, and diaper rash. Those are all things that are pretty common in children. So let's get started. Contact dermatitis, what is that? It's an inflammation of the skin that occurs in response to direct contact with an allergen or an irritant. So keep in mind, it doesn't have an immune response, but it's caused by an external irritant. So an example would be diaper dermatitis. So, that is caused by things that are irritating to the skin. So things like soap, detergents, lotions, urine, and stool can cause this. You also have the cradle cap, which is a type of dermatitis. And then you have allergic contact dermatitis. So this is a little bit of a delayed hypersensitivity reaction. So things like poison ivy, poison oak, rubber, latex, those things. So allergy contact dermatitis is an immune response where the immune memory is created, and from either long-term skin exposure or repeated skin exposure, this causes the immune response that we see. Some clinical manifestations or signs and symptoms of contact dermatitis are red bumps that can form moist weeping blisters, warm skin that's tender to the touch, a presence of oozing and some drainage and crusting. The skin becomes scaly, raw, and thick. So those are some examples of what that may look like. About treatment for contact dermatitis. So you want to clean the exposed area as soon as possible with cold water, remove the offending agents, and wash the exposed clothes and shoes. You can also try calamine lotion, cool compresses, and then wet dressings and colloidal oatmeal soaks to help relieve that itching. If it's very severe, they may have some antihistamines and corticosteroids. Oftentimes you see that with things like poison ivy and poison oak. Now we're going to talk a little bit about diaper dermatitis. It's a primary reaction to urine, feces, moisture, and friction. And then oftentimes it can be associated with antibiotic therapy and occur simultaneously with oral candidiasis, which is thrush. And that causing agent, if they get this in the diaper area, would be termed Candida albicans. So treatment for that is going to be a water impermeable barrier, things like that zinc oxide or Desitin. If they have the yeast infection, as you may call it, or the Candida albicans, an antifungal will be prescribed for those type of infections. So you want to make sure that you are instructing the parents. Some things that you want to do is to give them some education on using a super absorbent disposable diapers, change the diaper every 2 to 3 hours, wash the peritoneal area with warm water or a waterless cleanser, and make sure they're doing this after each bowel movement, and do not use commercial baby wipes. A lot of times they have a lot of different additives that could cause more irritation. And then, exposing that diaper area to air can help as well, applying that skin barrier and watching for signs of infection. Here you have a picture depicting the diaper dermatitis, and you can see this one's pretty severe. We're going to talk about bacterial infections. So the first one we're going to talk about is impetigo. This is the most common bacterial skin condition and it's highly contagious. It's a superficial infection caused by strep, staph, or both. The most common sites are on the face, around the mouth, and the hands, the neck, and the extremities. The classic presentation is going to be ruptured vesicles with a honey-colored crust, so it kind of gets a little bit crusty. So generally this occurs where the skin has been damaged or the area around the nose is irritated from nasal secretions. I've also seen this a lot with bug bites on the legs in the summertime. Let's talk about treatment for impetigo. So you want to look at the local area. So treatment for that would be to remove the crust and apply an antibiotic ointment. You may have a prescription or you may have triple antibiotic ointment. Then you want to make sure that you instruct the parents to complete the prescribed medication for a full number of days, whatever that may be, and observe close contacts and relatives for lesions. Again, this is really contagious. The infected child should not share towels or toiletries with others, and they should keep their fingernails short and clean because, like I said, they scratch and they touch, especially if there's a sore somewhere. And then, a lot of times this can lead to MRSA, so it definitely needs to be treated. So again, preach good hand hygiene, and then also washing clothes and linen separately with detergent and hot water to kill that bacteria that's on there and prevent spreading. Here you see a picture of impetigo, kind of some of those crusty areas on there. Let's take a look at this question. The school nurse has provided an instructional session about impetigo to parents of the children attending school. Which statement made by a parent indicates the need for further instructions? So, we did learn that it's extremely contagious. It's most common in humid weather. But did we learn that the lesions most often are located on the arms and the chest? No, that is not correct, right? But what we did learn was it might show up in the area of broken skin, such as an insect bite. So what would you choose as the correct answer? C is the correct answer. So this question is asking you which answer is wrong. Good job. Fungal infections, oral candida thrush. This is a fungal infection usually caused by Candida albicans. The characteristics of thrush are white patches on the oral mucosis. The treatment for this is oral nystatin suspension, which is applied to the mouth or tongue after feeding. Keep in mind that the mother is also treated if they are breastfeeding. So what you do is swab the suspension on the surface and then allow the child to swish and swallow the remaining dose. As far as parental instruction, like I said, you want to talk to them about how to administer the medication and good hand hygiene because you don't want it to spread. And then, it generally occurs in children who regularly use a corticosteroid inhaler or if they've received antibiotics. You also see this in a lot of children that have altered immune systems, and keep in mind, the infant's immune system isn't that great, so you do see it more with those children. If they do have a corticosteroid inhaler, you want to educate the parents to always rinse the mouth well after using that inhaler. Sometimes parents often mistake oral thrush for mill. So that's kind of just some leftover formula or milk in the child's mouth. But just keep in mind, you need to educate parents that, that will rub off, whereas thrush will not rub off. Now we are going to talk about different dermatophytoses. The most common that you've probably heard of is ringworm. So these are all fungal infections that affect the skin, hair, and nails. So you've got your different types. If you notice, the first term in each one is Tina. So you have capitis, corporatus, crussus, and pedis. So the one that's located on the scalp, there's different medications, and those are listed there for that. You have the one on the trunk with those topical creams kind of being a different medication there, as well as shampoo. If you notice, there's an antifungal in each category, whether it be oral, or a cream. Then you've got jock itch. Most commonly, they use a topical antifungal with that, and then washing with a very specific sulfide. And then you also have the Tina pedis, which is athlete's feet. There's usually a broad spectrum topical antifungal used for that as well. So when educating parents about these fungal infections, you want to instruct them to avoid sharing any hair accessories, brushes, or hats, as well as shoes, and take medications as prescribed. So keep in mind that ringworm can spread from one person to the other. It can also be spread by animals or by contact with a contaminated object. So you want to encourage cotton socks, wearing shower shoes in public showers and things like that, especially when dealing with kids, because you think about athletes' feet, and they're hot, they're sweaty, they're playing sports and things like that. So that's important to know. Dermatitis, or as eczema. This is a chronic condition. It's a skin disorder that involves scaly and itchy rashes. It's associated with a family history of allergic conditions. There is a risk for asthma with this. Some clinical manifestations that you will see are patches with vesicles, exudate, dryness, scaling, and itching. And as far as distribution of the rash and where it will be on infants, it's usually on the cheeks, scalp, trunk, hands and feet, extensor surfaces, and extremities. With children and adolescents, you'll see it more on those flexural areas like wrists, ankles, and feet. It's pretty symmetrical. A lot of times you see it around the elbows. Talk about treatment for eczema. So it's very, very important to hydrate and lubricate the skin. You want to encourage tepid baths with or without soap. Use gentle body washes and cleansers instead of regular soap. You want short, cooler baths are better than long, hot baths. Unscented ointments or creams such as Aveeno and Eucerin are very helpful with eczema. You also want to focus on reducing pruritus. So you want to relieve that itchy skin by using a moisturizer. Sometimes they have topical steroid creams or other prescribed creams. Encourage taking antihistamines to reduce some of that severe itching. Dressing in cotton clothing, avoiding wool and synthetic fabrics, and avoiding extensive heat. So kind of those three areas that you see listed there are going to help reduce those symptoms of itching. And then you also want to try to determine the trigger or the flare-up. So, is it food? Is it clothing, pets, soaps, perfume, fabric softeners, medications, things like that. Now you see a pretty severe case of chronic eczema on this little guy. So that being said, with what we have learned, what else is this child at risk for? Do you think they may be at risk for asthma? Thing that we see in pediatric patients is acne. It's a chronic inflammatory disorder of the hair follicles on the face and the trunk. This also poses a threat to self-image for adolescents. If you think back to the beginning of the course, we talked about those developmental stages, and what do those adolescents focus on? Generally, when they get acne, they are in that stage of identity versus role confusion, and they're very concerned about their image. Some clinical manifestations that you see with this are comedones, papulas, pustulas, nodules, cysts, and scars. So some treatment for acne is topical retinoids, benzoyl peroxide, antibiotics, oral contraceptives, and there's several other things out there. So you want to encourage these kids to avoid touching, picking, or popping them, and use oil-free products. They also want to cleanse their face 2 to 3 times a day with a mild type soap. At this point in your education, you know how important providing patient education is. So some things with acne that you want to educate patients on is encouraging good hand hygiene, avoid that picking and squeezing of the lesions, and cleaning the skin with mild soap and water at least twice a day. You also want to correct misconceptions about dietary causes because there are no links to food. It's usually caused by hormonal changes and issues and clogged pores. You want to discuss the importance of adherence with any prescribed plan. You know, you've learned about kids a little bit so far, and they're not always great about any type of regimen, especially if it's out of the norm, such as taking a medication. So significant treatment might not be seen with these patients for about 6 to 12 weeks. You also want to avoid sun exposure and teach about the prescribed meds and the adverse effects. With some of them, you have photosensitivity, elevated cholesterol and triglycerides, suicidal ideations, depression, and teratogenic effects. We're going to talk about pediculosis capitis, or lice. And I'm just going to tell you, I absolutely hate talking about head lice because it always makes me itch. A lice infestation of the hair and the scalp is what we're talking about. Some clinical manifestations are pruritus, a complaint of dandruff, and nits. Keep in mind these nits look like silvery white 1 millimeter teardrops, and they adhere to the side of the hair shaft. They're, a lot of times with dandruff, you can kind of blow on it and it'll move. With head lice, you have to pretty much take your nails and scrape it down the hair shaft. So treatment for this is going to be a shampoo or a permethrin cream. Nix is pretty common. Keep in mind that, that only kills the live lice. It does not kill the eggs. So you have to wait until those eggs hatch out and do that second treatment about 7 to 10 days later. Generally, this occurs in all socioeconomical levels. So don't think that just children who maybe live in poverty or are dirty have this, because anyone can have it, and it's most common in ages 4 to 11. Keep in mind, head lice can't jump. However, in school, a lot of times these are transmitted a lot. So be thinking about what kind of education do you need to provide. Here's just a little funny picture about when head lice, you get that letter from school that your kid has head lice. It's kind of a little bit freaky. This is just a little funny cartoon about when you get the letter from school that your kid has head lice. This is a picture that kind of shows the nits and where they are towards the scalp. A lot of times you'll see several in one area. And then sometimes you'll see like the kid will be scratching their head a lot, and even at the base of their scalp by the back of their neck have reddened areas and things like that. Lice are kind of transparent and kind of hard to see, and they can be all different sizes. Talk a little bit about scabies. This is a parasitic skin disorder caused by an infestation of the scabie. It's transmitted by close personal contact. As far as assessment wise, you'll see some pruritic papular rashes, and there are burrows into the skin And there's like fine grayish red lines that might be difficult to see. But basically, they burrow into the skin so that they can defecate and lay eggs. So you'll see severe itching at night a lot of times, and a rash on hands, axilla, finger webs, genitalia, and the belt line. So some interventions with that are topical application of the permethrin to kill this. It's called Elimite, sorry. Instructions to the parents on how to apply the promethazine will also be needed, and instructions on cleaning the environment. So now let's look at a picture of a scabies. This is that rash from scabies that you'll see. You can see where they've kind of burrowed into the skin there. Next, we're going to talk a little bit about burns. You are going to have some questions about this as well as other things in the PowerPoint on your exam, so make sure that you're studying these slides and this content. You also had a CET due this week that also pertains a little bit to burns. So just keep in mind that burns are in the top 5 leading causes of injury and death in children between ages of 1 and 14 years of age. Why? Kids are curious, right? So there's different types of burns. You've got thermal burns, and those are the most common in children. This can be caused by flames, scalds, grease, wood stoves, hair straighteners, and then you also have chemical burns. So this is caused by a causing agent by touching or ingesting it. So different chemicals in your household that you clean with, if they ingest them or touch them, that can cause a chemical burn. Then you have electrical burns, plug-ins. Keep in mind that kids love to explore and they bite cords a lot. My little nephew did this pretty often. They don't learn very well. Radiation burns as well, so things like sunlight or radioactive substances. So you can see where sunscreen is very important to prevent that. Have a little bit of education on burns, so this should just be a review. So the depth of the burn determines the degree of the burn. So you've got 1st degree, 2nd degree, and 3rd degree depicted here. Do you remember what type of pain, if any, are associated with each of these burns and what those burns look like? When we look at treatment for burns, the goal is to decrease the fluid loss, prevent infection, control pain, promote nutrition, and salvage any viable tissue. So to start out, to treat the burns, you want to assess the burn severity. That's going to be determined by the percentage of body surface area affected. There's a system grading that you may use, such as minor, moderate, or major. So in that initial time frame, the treatment will consist of airway and breathing and then circulation. So, you're assessing to see, have they inhaled any flames or ingested any substances, because that is what can affect the airway, right? So if it's an external burn, you're going to want to cover it with a clean cloth and then cleanse with mild soap and tepid water for minor burns. And then you also want to make sure that they are getting their tetanus vaccine. When we look at treatment for those major burns, we're going to be focusing on fluid replacement because that's necessary to maintain the cardiovascular and the renal system. And then preventing infection is a main thing, managing that pain, providing nutritional support. So, you're looking at additional protein and vitamin C to help with that wound healing. When we talk a little bit about managing pain, there may be aggressive pain management, especially with those major burns and moderate burns, and they may end up needing IV opioids that are scheduled. And then, there's also monitoring for signs and symptoms of septic shock restoring mobility, and providing psychosocial support. Keep in mind with some of these very severe burns and moderate burns, they may have dead skin that has to be debrided, and medications that consist of some type of silver ingredient to, help heal and prevent infection. Here you see a slide that just kind of shows you the percentage of areas that can be affected with children. You see the age and the percentages. If you look at the younger children, the head is a larger percent when they're younger than as they're older. So if you look, the percentage on a 1-year-old is 19, and the percentage on a 15-year-old drops down to 9%. Take a look at this question, pause the video, and then I'm going to give you the answer. All right, the answer is going to be B, A, and D. So all of those findings are consistent with septic shock. So an increased body temperature, altered sensory, and a decreased urine output. This is a pretty short lesson, so be sure to go and explore these websites to learn more.